Hello everybody, welcome to number 1 Doctor channel. Today we will talk about hemorrhoids, piles, functional anatomy. Continence is partly a function of the anal sphincters and partly a consequence of the anal cushions. The anal cushions comprise highly vascular tissue lining the anal canal, with a rich blood supply from the rectal arteries, which anastomose with the draining veins both through capillaries and through direct arteriovenous shunts. The draining veins form saccules, commonly just below the dentate line, which then drain via the superior rectal vein. The venous saccules are supported by smooth muscle to form the cushions. A position of these subepithelial vascular cushions is important for continence of flatus and fluid. Classification: hemorrhoids, or piles. The words are synonymous, may be classified according to their relationship to the anal orifice into internal, external and entero-external. Internal hemorrhoids are congested vascular cushions with dilated venous components draining into the superior rectal veins. External hemorrhoids is a term that should be abandoned, as it is applied to a conglomeration of quite different entities including perianal hematoma, thrombosed external pile, the sentinel pile of Fisher and Dano and perianal skin tags. Strictly speaking, internal piles that prolapse should be termed entero-external hemorrhoids, but this term is seldom used except by literary perfectionists. Pathology: internal hemorrhoids, or piles, are abnormal anal cushions, usually congested as a result of straining at stool, and traumatized by the passage of hard stool. The anal cushions are particularly prominent in pregnancy owing to the venous congestion caused by the large gravid uterus and the laxity of the supporting tissues caused by the influence of progesterone. With the patient in the lithotomy position, the usual arrangement is that 3 major piles occur at 3, 7 and 11 o'clock. Grading of hemorrhoids: first-degree hemorrhoids are confined to the anal canal. They bleed but do not prolapse. Second-degree hemorrhoids prolapse on defecation, then reduce spontaneously. Third-degree hemorrhoids prolapse outside the anal margin on defecation. They may be manually replaced by the patient. Fourth-degree hemorrhoids remain prolapsed outside the anal margin at all times. Predisposing factors: most hemorrhoids are idiopathic, but they may be precipitated or aggravated by factors that produce congestion of the superior rectal veins. These include compression by any pelvic tumor, of which the most common is the pregnant uterus, cardiac failure, excessive use of purgatives, chronic constipation and a rectal carcinoma. Occasionally, anorectal varices, similar in appearance to oesophageal varices, coexist with hemorrhoids in patients with portal hypertension since the anorectal area is the site of portosystemic anastomosis between the superior and inferior rectal veins. Clinical features: rectal bleeding is almost invariable. This is bright red and usually occurs at defecation. In the case of first-degree piles, this is the only symptom. More extensive piles prolapse and may produce a mucus discharge and pruritus ani. The prolapsed piles may result in soiling. Note that pain is not a feature of internal hemorrhoids except when these undergo thrombosis. When a patient complains of an attack of piles, it often means that some acute painful condition has developed at the anal margin. The most common and dramatic is strangulation of prolapsing piles leading to thrombosis. Apart from this, acute pain may be due to the following: Fisher and Dano, perianal hematoma, perianal or ischioanal abscess, tumor of the anal margin, proctalgia fugax, benign episodic pain relieved by digital dilation of the anal sphincter. Every patient presenting with a story suggestive of internal hemorrhoids is submitted to the following procedures: 1. Examination of the abdomen to exclude palpable lesions of the colon or aggravating factors for hemorrhoids, for example an enlarged liver or a pelvic mass, including the pregnant uterus. 2. Rectal examination. Internal hemorrhoids are not palpable but prolapsing piles are immediately obvious. The presence of prolapsing piles does not exclude a lesion higher in the bowel. 3. Proctoscopy, which will visualize the internal hemorrhoids. 4. Sigmoidoscopy is performed routinely, again to eliminate the lesion higher in the rectum, proctitis, polyp or carcinoma. Contrary to its name, The rigid sigmoidoscope does not afford a view of the sigmoid colon, hence sigmoidoscopy here is more correctly termed rectoscopy. 5. Colonoscopy or flexible sigmoidoscopy is carried out when symptoms such as alteration in bowel habit point to a more sinister condition than internal hemorrhoids. Computed tomography colonography is carried out when fiberoptic colonoscopy is not readily available. Complications: anemia, following severe or continued bleeding. Thrombosis. This occurs when prolapsing piles are gripped by the anal sphincter, strangulated piles. The venous return is occluded and thrombosis of the pile occurs. The prolapsed hemorrhoids are swollen often to the size of large plums, purplish black and tense, and are accompanied by considerable pain and distress. Suppuration or ulceration may occur. After 2-3 weeks, the thrombosed piles become fibrosed, often with spontaneous cure. Treatment. Before commencing treatment, it is essential to exclude either any predisposing cause or an associated and more important lesion, such as carcinoma of the rectum. Conservative management. Ideally, the patient should avoid straining at stool, and aim to pass a firm, soft motion daily. A bulk laxative, together with advice on inadequate fluid intake, are often required. Sclerotherapy. This is suitable for first and second degree piles. 2 to 3 ml of 5% phenol in almond oil or Mrcs oil is injected above each pile as a sclerosing submucous perivenous injection. The phenol sterilizes the oil, which is the main sclerosant. Because the injection is placed high in the anal canal above the dentate line, it is painless. 1 or more repeat injections may be required at monthly intervals. Banding. Application of a small O-ring rubber band to areas of protruding mucosa results in strangulation of the mucosa, which falls away after a few days. It can be successfully applied to first, second and third degree piles, but care must be taken to position the bands above the dentate line, lest the patient should feel the application. Surgery is performed for third and fourth degree piles. There are 2 principal procedures. 1. Stapled hemorrhoidopexy uses a circular stapling device to excise a band of mucous membrane above the dentate line. It also interrupts the blood supply to the piles. 2. Hemorrhoidal artery ligation (HALO) involves using a Doppler probe to identify the hemorrhoidal arteries, which are then ligated above the dentate line. This may be combined with plication of rectal mucosa if the piles are large and prolapsing. Hemorrhoidectomy involves excising the piles after first ligating the vascular pedicle. It is being largely superseded by the alternative techniques. Thrombosed strangulated piles. Conservative management is instituted for these. The patient is placed in bed with the foot of the bed elevated. Opiate analgesia is given for the severe pain, which is also eased by local cold compresses. Often the thrombosed piles fibrose completely with spontaneous cure. Many surgeons carry out hemorrhoidectomy at once in these patients. Specific complications of hemorrhoidectomy. Acute retention of urine. This is the result of acute anal discomfort postoperatively. Stricture. This only occurs when excessive amounts of mucosa and skin are excised. It is important to leave a bridge of epithelium between each excised hemorrhoid. Postoperative hemorrhage. This may be reactionary, usually on the night of the operation, or secondary, on about the 7th or 8th day. The bleeding may not be apparent externally, as the source of hemorrhage may be above the anal sphincter, with the blood filling the large bowel with only a little escaping to the exterior. General treatment comprises blood transfusion if hemorrhage is severe, as evidenced by the general appearance of the patient, a pulse raised above 100 and a systolic blood pressure below 100 mmHg. Local treatment is carried out under general anesthetic in the operating theater. The blood is washed out of the rectum with warm saline. Occasionally in reactionary hemorrhage, a bleeding point is seen and can be diathermate or suture ligated. More often, there is a general oozing from the operation field, and the anal canal requires packing with gauze around a wide-bore rubber tube, which allows evacuation of flatus and escape of any blood from the bowel. The tube and gauze are removed after 48 hours. Perianal hematoma. This lesion, which is also termed a thrombosed external pile, is produced by thrombosis within the inferior rectal venous plexus. Unlike internal hemorrhoids, it is covered by squamous epithelium supplied by somatic nerves and is therefore painful. The onset is acute, often after straining at stool, with sudden pain and the appearance of a lump at the anal verge. Local examination shows a tense, smooth, dark blue, cherry-sized lump at the anal margin. Untreated, this perianal hematoma either subsides over a few days, eventually leaving a fibrous tag, or ruptures, discharging some clotted blood. Treatment. In the acute phase, immediate relief is produced by evacuating the hematoma through a small incision, conveniently performed under local anesthetic. If the patient is seen when the hematoma is already discharging or becoming absorbed, hot baths are prescribed and reassurance given that all will soon be well. Thanks for watching. Please like and share our videos and subscribe to our YouTube channel Number 1 Doctor. With my best wishes. Dr. 8 Famid.